Good afternoon, everybody. Welcome to the next episode of Digi4Care project. My name is Semmelweis today, and I will be your host today, along with my two guests. The first one is Viktória Vadas. Viktória, thank you for coming.
Thank you for calling us.
And the second one is Tiboldi.
Hello.
Did I pronounce it correctly?
Yes, you did.
Okay, so my first job is done and I'm very proud of it. Viktória, at the beginning, could you please introduce yourself? Where do you come from and for which employee do you work for?
Yes, my name is Viktória Vadas. I'm an anesthesiologist, specialist doctor from Hungary. I work in Budapest and I'm representing Semmelweis University.
Semmelweis University, one of the most famous universities in Central Europe.
Good to hear.
Thank you. Ákos, what about you?
Well, I'm also an anesthesiologist and an intensive care physician. I work in Vienna right now in the biggest trauma center of the city and of Austria. But also an Hungarian. I live in Hungary. And I do my research projects in the Ludwig Boltzmann Institute, which is a network of institutes in Austria, dealing with different kind of research.
Yes, how many years do you work in Austria?
Well, I moved to Austria 2003, did my qualification there. I finished my medical school there, then I did my specialization for anesthesiology after 3 years of Germany, also in Austria, so, well, more than 20 years.
Nice, thank you so much. The main topic of today's podcast is the digital ultrasound revolution in managing cardiovascular and diabetes patients, but before we approach this topic, before we met, I found out, or better said, you told me that you have met as colleagues, especially because of this project. Is it true?
Yes, absolutely.
So, when was it?
It was just last year, January, when this project started, and luckily we have the same specialty, so we understand quite well each other's language, even though we are not working in the same country and in the same system.
Out of curiosity, and it's a common question for both of you, why did you decide to be anesthesiologists?
Should I start?
Yeah.
Whoever prefers.
Well, I wanted to do emergency medicine. I wanted to be an emergency physician. In Austria, there is no specialty for that. There are only internal medicine, which you can specialize for. And I thought, being anesthesiologist is interesting because you can deal with emergency cases and critical cases. However, I learned to love very much my specialty, and I am a full-hearted anesthesiologist now, so that was the way. It's
crucial that you are full-hearted because one of the topic is cardiovascular diseases. So let's start with the introduction to the main topics. And the first question, Viktória, for you is, what is POCUS, or I will translate it, point of care ultrasound, and why is it important in pre-hospital care of the patients?
Yes. Well, Semmelweis University is doing this project, this pilot, with the National Ambulance Service of Hungary, which is quite a big company, we can say. They do the pre-hospital care in Hungary. But the POCUS, as you asked me, the digital tools are getting in an everyday use in our life, in the clinical life. These tools makes our life much more easier in the everyday life.
In what way?
We don't need another doctor, like radiologist, to make a quick diagnosis for patients. And sometimes, as Ákos mentioned, it's an emergency patients who we are dealing with, and we need to make decisions quickly, right next to the beds, and this makes us much more free, and we can do our better job with these tools, I think.
So you also mentioned, or Viktória mentioned, that this new method of diagnosis is the future of the current medicine. How is the new technologies progressing and helping you in your everyday life as a doctor?
I just would like to come back to the point how POCUS, point of care ultrasound, developed actually, because this is the basic of this new technology, or the new implementation or use of this technology. Doing ultrasound is still, but it was always a highly specialized field. It was a radiologist specialty. So if you are a radiologist, or if you are a cardiologist, then you can do a special ultrasound of the heart. You are trained for it. You have huge ultrasound machines which cost a lot of money, at least 100,000 euro or 50 to 100,000 euro, and it's bulky, it's huge. If you are a radiologist, you also use the same equipment. These equipments are not, and also the very high satisfied knowledge behind it, it's not usable and not feasible for a fast decision making in an acute care situation. And
because it is too sizable?
It's big, it's slow, it takes time. It's a machine which stands on a stable position, and patients come to stable. They have to lay down and they will be examined. But anesthesiologists and ICU care physicians and emergency physicians just wanted to use the benefits of ultrasound imaging for decision making. And that's why companies just developed smaller ultrasound machines. For a very special part of anesthesiology is the regional anesthesiology first.
Regional?
Mm-hmm. It is a kind of anesthesia where you inject local anesthetics around the nerves, and to make it secure, you can use the ultrasound because you can visualize veins and arteries and nerves with the ultrasound, and you can inject the local anesthetics. It's very similar to what the dentist is doing if you have something at the dentist office. You just get the injection. That's a local anesthesia. But we do it for the arms and for the legs as well. And around 10-15 years ago, I think, it started to have a peak in anesthesiology using ultrasound bedside. So not bringing the patient to the ultrasound machine, but bringing the ultrasound machine to the bed.
So the machine follows the patient.
The machine follows the patients. Companies started to develop smaller machines, and doctors used the ultrasound machines not only for this regional anesthesia, but also to check the heart, check the belly, check all other organs with it. So the bedside ultrasound was started to be a part of our everyday use.
Can point of care of ultrasound can be used also outside the hospital? For example, when you have emergency situation, did you just bring this device and use it in the field?
Yes, that was the next logical step. I think I cannot say the date, but around since 10 years we have in different emergency services, we have ultrasound machines placed on in ambulance cars or in the physicians' cars and rapid emergency cars, where they can bring the tablet with a with an ultrasound probe. An ultrasound, the probe is the name of the thing what you have, and it's the hand. There's a product what you have in your hand, and you can connect the two things, and you can do imaging. It was a technological question because to provide an ultrasound image deep enough in the body, you need a lot of energy, and that was always the problem, that you needed machines which are capable to produce energy to make these images. And it was a technological development. And along with this technological development, the medical development also started, because medical societies just developed protocols which can be used not only by highly specialized radiologists or cardiologists, but also not so highly specialized medical staff like we are anesthesiologists.
Well understood. Basically, today's topic is the digital ultrasound revolution in managing cardiovascular and diabetes patients, and how is the POCUS related to this topic?
These groups of the patients are quite often in an emergency situation, and most of them can get quite easily to the hospitals in emergency situation, or to operating rooms as well. So if you have cardiac problems or diabetes,
or both,
yes, and they are mainly they can walk together. So if you have diabetes, probably soon you will have any kind of cardiovascular disease as well, quite soon.
Yeah.
And if these patients are not in a good condition, or they don't take their medications regularly, they are smoking or something else which shouldn't be done, they can have severe problems, medical problems.
Okay, and how? So basically, and POCUS, how is helping with those patients who are about to be hospitalized, etc.?
I would say ultrasound doesn't help the patient. Ultrasound helps the doctors and the healthcare professionals to make the diagnosis easier and quicker. So if you ask why is it in pre-hospital care is mainly before the hospital, so like ambulance care or the GPs, we can say that as well. We can make the decision, we can set up the diagnosis before they get into the hospital, so if we can start to treat them before get into emergency rooms.
Dr. do you want to add something?
Yes, it is. Do you know the phone endoscope, the stethoscope of the doctor? And the stethoscope doesn't cure anybody, but it is our ears listening what happens in the body. And the ultrasound is our eye to see what's happening in the body. So if we have the technology, which is small enough right now, because I don't need this bulky, huge thing to have an image, my iPad or my phone is enough for that.
So basically, once you take a picture with this technology, it can be displayed on your. You have, for example, your tablet in front of you, or it can be displayed on a regular smartphone.
Yes, you have to connect, or you can connect this probe if you want with a wire to the iPad or to the tablet. It doesn't have to be a specific one, to a tablet or to a smartphone.
It's for universal devices.
It's universal. As nearly all of the devices has a USB-C connection, and it's important because of the energy.
Yeah.
It's universal, and you can have power through this, enough power to make the probe functioning.
You have mentioned before that one of the challenges related to POCUS was the energy. So how is now POCUS is being? What's the stream of their energy. Does those devices use batteries, or it needs to be plugged into the electrical web?
No, it uses the power of the tablet or the phone, and the technology is inside in the probe. It was in the past. It was like a huge computer tower. This was the technology, and the probe was just the plastic, but they managed somehow to put the technology in the probe, which is just this handheld thing.
So it all has shrink to the minimum.
Shrink to the minimum, yes. Of course, you don't have the best image quality like with a beautiful, huge device.
Not the best, but sufficient for your purposes.
It's enough. It's more than enough to make small and fast decisions.
Yes, but it depends on which company's product are we talking about, because some of them has their own monitor. So the point of care doesn't mean it's just the head of the ultrasound. It means a small thing that you can take next to the patient to the bed.
And it is important, thank you, that you at the point of care ultrasound just means I take the ultrasound machine, any kind of, it can be the big one as well, and go to the patient, and I use the ultrasound in a situation where it helps me to find a diagnosis. It is not it's not an examination which the cardiologist is doing to make an oral examination of the heart. I have a problem, and I use this tool together with other tools to solve this problem. That's why it's point of care.
Out of curiosity, what might be the future or the progress? Because now you can use this ultrasound with your phone or with something that is totally shrinked. This is the thing that we are using on everyday life. So what's the future of this ultrasound?
I would say the future is not about only just the technology. The future is what we are piloting in Pilot 2, that we can bring the technology very close to the patient without the expert knowledge being on the site. Because we can use the mobility of this point of care ultrasound and the point of care every kind of tests, because we can do lab tests as well, not just ultrasound. But we can use the ultrasound in an ambulance car without a radiologist or without a specialist who can use it perfectly and without any question, because in our pilot we are teaching other healthcare professionals how to switch it on, how to put it on, where to put it on. If the expert asks to show me a picture, I understand what he's saying.
And basically you can do it remotely and have a consultation with other colleagues who might not be on site, but they are somewhere else, wherever in the world, wherever in the country. Why is the patients with the cardiovascular or diabetes or both of those diagnoses ideal group for testing of those new technologies?
Because they have very often a cardiac arrest. They have very often a heart failure, not because of a heart infarction, but another cause. They have vascular diseases and problems. So you can diagnose malfunction of the heart. So you can just look at the heart and see whether it pumps well or not. You can look at the heart and see if there is one part is bigger than another one, which should not be in case of any pulmonary embolism. It's a diagnosis. It's a diagnostic which is done within a second. You don't have to measure anything. You just look at it, just check it for 10 seconds, and you have the diagnosis. It's very easy, very obvious. Or you can check the vessels. You can use the ultrasound to get vascular access in patients like cardiovascular disease patients have very complicated or very not so easy to have vascular access, like a needle in the vein. So you can use the ultrasound for this as well. I think we choose this patient group because they are very heterogeneous.
And plus also because of the amount, because really
there are a lot
millions
of,
of people
and
all
that's
around
what
the
I
world.
wanted to say. It's the practical answer. Lots of them. We have lots of them.
And the number is growing in addition, right?
Yes, and the age is going down. So because we have lots of young ones who are overrated, who are not treated, who started their hypertension in an earlier age. So the practical answer is because we have lots of them, and we need to treat them because we need them in the next years and decades.
Understood. Oh, in this pilot project, what digital tools are being tested in the pilot project?
The ultrasound.
Yeah, of course. We've mentioned that.
Yes.
Any additional?
This one is the main topic, but the focus is on the teaching. How can we teach them remotely without expert on site? And how can we teach them on site with the expert?
So basically it's the next step in education, not of the patients, but not of the doctors. And as far as I can understand now, it also might be the reply towards the trend that is the whole Western civilization facing, and that's insufficient amount of doctors and nurses in general?
It's a combination, because of course you have a lack of specialists, but on the other side you have a growing amount of reachable technology, and you have standardized examination procedures, like different procedure for point-of-care ultrasound, which is reachable for a lot of people, a lot of doctors, and or not only doctors, healthcare professionals. Until now, it was a specialist duty, the cardiologist, the radiologist duty, but now it's reachable for everybody. So we have to examine how to teach these people to deal with this technology which is growing, and to use these easy to understand and easy to learn protocols.
I think we need even to go to one step backward and to answer if the medical professionals are willing to be educated in this, or if they are sort of conservative and they are reluctant towards having new trends from telemedicine.
Well, it's a good question.
Well, I would like
It's the best answer. If you don't want to answer some tricky question, you just say it's a good question and move forward.
Let's think about COVID.
No, but it opens a lot of things. That's why I just want to...
Let's think about COVID. In COVID, we had lots of patients very quickly in the ICU, and we didn't have the right answers and the right treatments in the first few weeks, months, years, I would say, the first year. So we needed to find a way how we can help each other, how we can help ourselves.
And help patients.
And the patients, yes. But now, in Austria, they have this teaching system, so with this, we are able to get their knowledge without meeting, without personal contacts.
So it can be done remotely.
Absolutely. Or if we think about wars, we are not able to go to a country where there is a war, so we can help them with telemedicine through these technologies, these digital technologies, and we can teach them how to use them with this remote technology.
Yes, and it's an important point that you brought in, is telemedicine. Telemedicine is actually a growing
industry.
You can say industry. We are still searching for the position, in medicine, in healthcare, where is feasible and where not. But we use telemedicine in case of critical care, intensive care, because COVID is a very good example where it started, that specialist ICU physicians helped not so very experienced colleagues to deal with patients and with problems which they were never faced with before. Because if they had a problem, they just transferred the patient to the centrum. But in COVID they could not, because there was no lack of capacity, no availability, and so on. So they started to do the rounds, the ICU rounds, remotely.
What's ICU?
Intensive care unit rounds, so the everyday discussions about the patients, remotely from a centrum in another hospital. So they just brought their expertise in another hospital remotely. And this is actually what it was always existent in the medicine, because you just always ask an expert. You called them on the phone, or wrote an email, or wrote a letter 200 years ago, whatever, and ask experts about their opinion.
Send the pigeons.
And send, yes.
I don't want to be cynical, but in that case, patient might have died during the flight of the pigeon, of course.
Yes, but now we have a digital system, a digital technology improvement in the last decade, which we can use for that. And ultrasound is just a use case to implement telemedicine. It's just
one particular scenario or example.
Just a very practical scenario, because these companies just developed ultrasound machines which can do telemedicine. So you not only you yourself see the picture, but you are capable to send this image live to another person who is sitting in front of a laptop or another iPad.
We would have to describe the difference between educating doctors of using this technology and of educating themselves in using it in a more traditional way. Face-to-face, when the patient was on site, not maybe thousands of kilometers, as Viktória has mentioned, maybe during the war times. What would be the answer? What are the main differences in education? Is it trust of the doctors?
I wouldn't say in these days, I wouldn't say there would be much difference, because we just tested it and it seems that this way is working. So there is not much difference between having the expert on site or via the camera. Because we have the technology now.
We are used to it more than we used to be.
Absolutely.
5 or 10 years ago.
Yeah, now everybody has a smartphone, everybody can connect, they are watching social media, they are doing self-pictures, so it's a common thing to use. So it doesn't matter whether it's in my work time or in my private life to use my phone or my camera. It's very common now, so I don't think it's a problem. If we have a good internet connection, if we have a good device, microphone, cameras, it's not a problem, I wouldn't say.
And also the crucial is the internet connection, and it has to be sufficiently fast in order to transfer maybe the bigger loads of the data that we were used in the past.
Yes, it is. And these are, of course, the disadvantages as well of such an implementation, that you are very
reliant on the technology?
Reliant on the technology and technological problems. So if you have a technological problem and you have no staff there at the site of the teaching, where you want to teach somebody, you cannot, it is 500 kilometers away, you cannot solve the problem remotely. Or you have an internet problem. you cannot solve it, you cannot do the teaching. But on the other side, you have massive benefits because you can give this kind of knowledge to a much wider group of healthcare professionals, which group would not travel long distances in a very well-defined time to have a course, because they don't have time, and because, or not too much interest. But we know that we can elevate or improve the quality of health care, actually, what we provide with these technologies and with these new protocols. So we have to provide these people this kind of education.
And another point of view, sometimes the experts are not available at all in a part of the world, or in a part of a hospital, or something inside in a country. So we can level up the number of the experts via telemedicine.
And we can use probably the subject matter experts all around the world in order to help. So somebody is still awake because of the time zones, etc.
But it was very important in this pilot to examine whether the two kinds of education are interchangeable or not. And that's why we developed this model, this educational model, which uses objective measures to examine if we educate one group only online with telemedical tools, and the other group with a conservative face-to-face
And it's education
method.
Towards doctors, right?
No, it
Or
was education of
staff.
healthcare professionals. It was a second step further to make it generally acceptable in the health profession, that we have chosen paramedics.
Mm-hmm.
So we want to show that actually using this ultrasound technology, using these protocols, it is also for in health educated person, it's easy to learn it.
In this pilot project, can we specify how many patients were tested at each site of this whole educational process?
We have to talk here about, in the educational teaching, we have to talk about participants, because there were no patients involved, because the participants were the healthcare professionals who have to be taught about the new technology. 15 or 45 in Hungary and 45 in Austria.
So 90 combined.
Because there was a power calculation for these objective scores. There is an objective score of ultrasound education. OSAU score is the official name, and we calculated from previous publications. So we needed around 90 participants for this.
90 combined.
Combined and randomized.
What would how randomized in this scenario?
Well, with a randomizer, there are softwares to randomize them into groups, because the inclusion criteria was healthcare professional who has no previous education in point of care ultrasound, or did not do more than 20 point of care ultrasound. So actually ultrasound naive healthcare professionals. They were just randomly chosen or just split it into groups, the face-to-face and online group.
And do you see any differences, or do we already have some outcome of the pilot?
We have preliminary results from the secondary outcome. The secondary outcome was the NASA score, which is a cognitive score. The cognitive effect
It includes mental demand, physical effort, frustration, etc.
Yes, and there was no difference in both groups. The primary outcome, the OSO score, takes a little bit more time because we faced some. Well, it was not an issue which we did not know. We knew it from the beginning. The whole experiment or the whole study is built up on many levels. The first level, you do the education face-to-face or online. Then both groups had to do an assessment because we have to test what they have learned. This assessment will be recorded. They have standardized questions which they have to do. It will be recorded, and these records will be analyzed by unbiased experts who were not involved in the study. But these experts, they are just, because this whole system comes from Austria, they are just Austrian, so speaking German and not Hungarian. So we have
You speak both?
I speak both, but I'm involved in the project, so I cannot be the expert. So these are experts, and also they are cardiologists, so they're really experts, not like me. And so first of all, we have to transcribe the Hungarian text to make them understand what educated persons just answered. It takes a lot of time, and it's a burden. What we did not think it's so complicated.
But if we would have to sum it up to the current level or to the current point, we did not see any disadvantages of the educating
yet.
of the medical professionals not remotely. On the contrary,
Actually, not. So the secondary,
was it surprising for you?
No.
No. Okay.
No.
Viktória, for you?
No,
Why?
because they had an online training first. That was the first line, and after that we had some saying before that it was a good course and they understood everything. So the medical language is not really English or German or something. You can understand it quite well, and
So it's universal language.
The language is one thing, and this digitalization that I mentioned before, it's very common. It's in our everyday life, so it was not difficult for them at all.
Can this project be sort of the turning point also towards the methods and the pathways how to educate medical professionals?
Yes, definitely.
This is one of our aims.
And then who would be, when we are speaking about with the medical professionals, sometimes we are forgetting about the crucial part of the chain, and is the patient. How will the patients benefit from all of it?
They can reach the expert knowledge without being in the same place with the expert.
So the patients could get top healthcare from top healthcare professionals remotely anywhere in the world, basically in any extremely difficult situations.
I would say that. And if we can use these technologies on time, when they really need it, quickly in the first few minutes, like when we have a cardiac arrest, when the heart stops working, we need to know what's the problem and we need to treat it right now. And when you have it in your hand and you have an expert on your ear through a telephone or through the camera with this ultrasound telemedicine connection, they can help you. So time is life-saving.
Time is precious.
Yeah, in this situation.
But also without the expert, because the expert is also a very luxurious thing to have somebody as well. But if we educate, if we stay now at the ultrasound, if we educate a lot of people using point-of-care ultrasound, we can easily change the pathway of the patient. We see it actually in Vienna. We implemented ultrasound in the emergency services 7 years ago, also with an expert. So we had very much experience how it works. If the doctor on scene is making an ultrasound and the expert in the hospital is sitting in front of the computer and watching what he or she is doing and communicating. So I also myself did this expert position a lot of times. So we have seen it works. But without the expert, the change how we treat patients at scene outside of the hospital changed a lot. Because I can redecide or can change my decision with the ultrasound and bring
based on data.
Based on the ultrasound and bring the patient in a completely different hospital where I would never bring without this knowledge. Because it's a centrum, I don't bring all of the patient to a central hospital because it's reserved for very serious cases. The diagnosis on the street is very limited. So you just bring the patient in any kind of emergency room.
Basically, we can improve the pathway of the patient and make it more smoother and more efficient because the patients will also, in a case of emergency or in a case they will need it, they will be sent to the specialized center or they will be sent to the center that is totally alright and able to take care of the patient diagnosis.
Yes, but also the therapy on scene is different because if I have no information, I would just do a basic care. But if I have the information in my hands or I see it with my eyes, I can make the therapy on scene as well.
And you can continue with personalized and precise medicine.
It's much more personalized medicine, yes.
And earlier, you can start the treatment already in the ambulance car if you know the diagnosis in the car.
Can we also say that that POCUS is also cost effective?
Well, it's a difficult question again because depends on the tool. Which one is the one and how is it working? So we have cheaper ones and we have really expensive ones. It depends.
Well, if you calculate, well, I cannot calculate it, but if you just just check a patient pathway. So I have a patient who has a dyspnea, so doesn't get enough air. I give this patient, without ultrasound, and give this patient an oxygen. I just listen to the lungs, I don't hear anything, and bring it in a hospital. In this hospital, they make a lot of examinations, lab and chest X-ray. They don't find anything. In some hours, days, the cardiologist will come, make an ultrasound of the heart, and figures out he has a heart failure. Now this patient has to be transferred to another hospital. There is a cardiological centrum where they do another specialized examination and so on and so on. If I have the ultrasound on scene and I'm trained and I think I can diagnose it, I just make an ultrasound at site.
So it helps you to decide which examination should patient take and under what circumstances.
And I can decide that I bring this patient directly to the cardiological unit because he has a heart failure. Because I see on scene that he has a heart failure. And this patient doesn't need this very long trip. If the healthcare professional doesn't have the knowledge to decide on scene, then he or she can use the expert in the background to decide with.
But meanwhile, time is running and time is money. And in the hospital, all the tests, all the specialists who would be involved, they also cost money. So that's why I said it's a difficult question. Because if we put on the scale all parameters on both sides, we wouldn't say that using of POCUS would be more expensive than not using it. So it depends on, but everybody can choose. But depending on whether you have money, whether the system has money for that or not, because if not, it's not a question whether we can buy it or not.
Thank you for watching Digi4Care podcast. Mine today guests were Viktória Vadas.
Thank you.
And Ákos Tiboldi.
Thank you very much.
My name is Simon Esnyák, and we are looking forward to see you again soon in the next episode.